One of the things I love about this conference is the massive variation in clinical practice, the interdisciplinary work, and in this case, the variation in research methods. We love the kind of the qualitative stuff. The storytelling people's stories is massively important in terms of shaping the way in which we organise our services. So we're going kind of right to the other end of the spectrum in terms of kind of quantitative research and meta-analysis. Both essential forms of research methods if we're going to tell the full story of social exclusion, multiple exclusion, homelessness. We published a paper a little while ago, one of the Lancet papers, around what works for whom. And part of that, the bit that I was interested in was the psychosocial interventions, and we found some evidence of effectiveness of psychosocial interventions for excluded groups. So we kind of got really interested in maybe what the detail around, as psychologists, we got really interested in what the detail about that might be. So where might it be useful, and what was the usefulness in homelessness? So that drove a kind of a research question around psychosocial interventions in homelessness. Now, the way in which we framed this is that we wanted it to be persuasive, particularly for people perhaps who read medical journals, because we want it to start to influence things like policy. Now that then drives a particular research question, because it drives in terms of the quality of the research that we want to assess. It tends to go towards randomized control trials. Now that becomes important later on in terms of what's included and what isn't included in the research, which Lily will cover. Lily's done the work. I'm going to stand here in a metaphorical sequin dress, which is an image you will never be able to forget.
Right. Okay, so we've covered a bit of that. Yeah, so when we started this review, there wasn't really some specific evidence on the effectiveness of psychological interventions, which then meta-analysed the results. So the point of this was to sort of explore and summarise the evidence that was out there. Specifically, we wanted to look at what interventions are being studied, which psychological interventions, and by psychological interventions we meant interventions that are underpinned by a psychological theory that's evidence-based. So we did this to capture interventions that are sort of utilised theory but might not be recognisable in name. So next we wanted to look at what the targets for those interventions were, so what outcomes are being tracked. And we kept this broad again to include any outcomes that might be potentially implicated in homelessness, psychological or behavioural outcomes. And then we wanted to see how effective the interventions are in improving those outcomes. Okay. So should we skip this?
Yeah. So in the interest of time, we'll skip some of the methodological stuff. It's only interesting to geeks who are really interested in this kind of stuff, which includes us, but you might not. So we'll skip a bit of the stuff just to get through to the implications.
So the research, the studies included had 13 different types of interventions, which included the more established psychological therapies, behavioural interventions that sort of operate on a reinforcement, and then some other interventions that were more bespoke and used psychological theory but aren't recognisable, like for instance HOVAST is like a Dutch intervention that is based on resilience and self-determination theory and strengths-based approach, but it's not that well known.
One thing that was really kind of pleasing to find was it wasn't just the established forms of therapy that had conducted randomized control trials. It was, some stuff that maybe came from a little left field and had been designed, and people had wanted to engage in a really good, robust evaluation. It's kind of nice to see.
And so in the included papers, when we were sort of synthesising the information, we found that they roughly fitted into sort of 6 themes, which is these. Psychological well-being sort of referred to the sort of skills and attitudes, beliefs that might influence general your sort of psychological well-being or psychological health. So like coping skills, mindfulness, that sort of stuff. So these were the results from the narrative analysis, we found that there was some good evidence for CBT for substance use, anxiety, depression, PTSD, and also psychological well-being, antisocial behaviour, but only a couple of studies looked at those outcomes, so it's sort of hard to know if that would continue if there were more papers. Motivational interviewing, it was interesting because the evidence for that for substance use was mixed, which we found surprising, but when we looked into the interventions more, we found that they tended to be sort of very brief and group-based, which is kind of a dilution of motivational interviewing. And there were some promising results for peer navigation, but there was only one study, so again, we would need some more research into that area. And what was particularly interesting is that the behavioural interventions tended to measure social stability, so that would be stuff like employment, education, access to medical care, days spent homeless and days spent in hospital, and they were effective for improving those outcomes. So where we had enough detail and where the outcomes were alike enough, we did some meta-analyses. So as Nick was saying, this sort of adds an element of robustness to the results. Yeah. Anything you want to add?
Yeah, so for the uninitiated into the dark art of meta-analysis, it's a way of combining many studies with different forms of measure. So you might be measuring anxiety, but you might use lots of different scales to measure that. It's a way of combining all those into kind of one overall score, effectively.
So the outcomes in red are what came out to be significant. So we've got PTSD, mindfulness, and hard drug use. And this is the psychological interventions as a group to begin with. And this is kind of like a visual representation of that table. So the ones with the asterisks are the significant figures, sorry. And
so you can see there, so we've got PTSD obviously with a really sort of interesting kind of fairly significant result, and mindfulness seems to come out overall as effective as interventions.
What was interesting as well is we seem to find that CBT seemed to be up towards the more effective end, favouring intervention for most of the trials across a number of outcomes. And similarly, if you remove sort of the less well-known interventions from anxiety and depression and stick with the more the ones with the greater evidence base, those two meta-analyses become significant as well. And anxiety in particular has quite a big effect, which was interesting. We'll skip through that. So yeah, to summarise, the psychological interventions were effective at improving drug use, PTSD, mindfulness, anxiety and depression if you remove the less evidence-based interventions. And yeah, CBT seems to be fairly effective. And it is also worth mentioning that, yeah, peer navigation and contingency management also had some good results, but there just weren't enough papers at the moment in those areas.
Contingency management is interesting, so it's very much about a very behavioural intervention, so very much about kind of reinforcement and applying reinforcement for reinforcing particularly kind of pro-social behaviours. There is a really interesting literature about how follow-up, and that sometimes when you remove when you stop and you remove the contingency, in other words, reinforcement, you tend to get a kind of deterioration. But there was some evidence over time.
Yeah, we were also aware that there were some interventions missing from the analysis, just because they weren't in the literature. So things like mentalization-based therapy and psychodynamic psychotherapy. Yeah, Nick, do you want to talk about this?
So this is a key point. So this systematic review and meta-analysis sought to ask a very particular question, and that question was defined by the inclusion criteria. So because we included only randomised control trials, because we wanted to go for the most robust effectiveness method, then of course what gets excluded is a load of other stuff where maybe it's a control trial or even a case series or other equally useful but not yet kind of robust over populations research methods. We know that we've got some early evidence with the work that we've been doing with Williamson and in Lambeth that a mentalisation-based approach can be really useful, but we don't have a randomised controlled trial method for that yet. So it just hasn't reached this form of literature. One of the kind of the maxims, I guess, in this area is that absence of evidence isn't the same as evidence of absence. So one of the implications is that some of the promising interventions in this area, particularly things like mentalisation, and there's a lot of work on psychodynamic therapies in this area and psychodynamic counselling and those kind of things, they just haven't yet reached the RCT literature. Now, some people might choose not to. Some people have a significant aversion to randomised controlled trials, and they do have their limitations. We talk about a kind of a continuum of ecological validity versus kind of robustness and statistical validity. And some of the stuff that I love about the narrative stuff that we saw before is it's very high in ecological validity. These are people's real stories, and there's a richness to that kind of data. But when we're starting to work across a population, that becomes more difficult. So we get into these randomised controlled trial methods. But they're just one small part of the story. You know, we need all of the kind of the research methods to tell the richness of stories around effective interventions in homelessness. So, you know, I guess the call is to develop the research methods and particularly funding. Randomised controlled trials are hard to do without funding, particularly if you want to get follow-up data. Follow-up data is really hard to get because obviously people disappear, people go to prison, people die, and purely for the kind of research method, we need to be following those up, and it's tough to do, so they need to be funded. So the building the kind of the research infrastructure in our area is partly kind of what we're trying to do and what we're trying to persuade people to do, so that governments like governmental departments like MHCLG start to take research funding seriously and start to allocate funding to do that kind of research. And that's not to say that controlled trials, uncontrolled trials, narratives aren't important, but we need all of the research methods available to us to be persuasive. That it?
Did you want to talk about this?
Yeah. Oh, the baseline diagnosis stuff.
Yeah.
So, one of the other limitations is that we get forced into thinking about diagnoses like PTSD, anxiety, depression, and the like. And what we know about our guys is that they have all of the diagnoses. And so it starts to make less sense. Now, one of the things that we're trying to do, Garda's doing a PhD, and she's looking at a kind of a trans-diagnostic approach, so looking at the phenomenology of what goes on. So one of the kind of the research methods we might think about in the future is setting aside the diagnoses and starting to look at controlled trials and RCTs on what matters to people. In other words, can we help people to improve the things which are meaningful for them? And we sort of talk about a meaningful behaviours outcome framework. So we ask people, what is it that's meaningful for you? And then does whatever the intervention is, does it help people do more of what they want to do and less of what they don't want to do? Now that's actually not so difficult to implement as it might be, but it doesn't easily fit into the RCT framework if you think that diagnoses are of primary importance. And right now, the kind of the RCT, I guess, frame of reference is things like diagnostic categories. So one of the things that we do need to do is also move towards a kind of a setting aside diagnoses and getting into what's very important for the individuals and then measuring that across populations. So that's the kind of people's work we're trying to do. We're also trying to do that with commissioners, so helping commissioners commission services according to how organisations can help people do more of what they want to do and less of maybe the things that are getting in the way of what they want to do. Did that cover it?
I think so.
Brilliant. Excellent.
Okay.
2 minutes early.
Okay. Yeah. Cool.